In this episode of the Nurse Practitioner Podcast, Rhonda Winegar discusses insomnia. Thanks for joining us today, Rhonda.
Thank you for having me.
Well, let's start with this. Why is sleep important?
Sleep is very important because it can make such a difference in your physical as well as your mental health. It can affect your relationships. It can affect how quickly you recover from illnesses. It can help with chronic medical conditions. So sleep is just all over important. It's one of the best things that you can do is get a good night's sleep.
What is insomnia, and is there a difference between acute and chronic insomnia?
Insomnia, it's difficulty going to sleep or difficulty staying asleep. Those are two different things. A lot of people will have difficulty going to sleep, which is known as sleep latency. And you shouldn't go right to sleep as soon as you hit the pillow. A typical normal sleep latency time or time to go to sleep is 10 to 20 minutes. So insomnia is that difficulty going to sleep as well as the difficulty to stay asleep. Some people will have no difficulty going to sleep, but they'll have multiple awakenings throughout the night, so that can contribute to sleep quality. That also weighs into insomnia. So we don't typically call someone having insomnia unless they've had at least 3 nights where they've had difficulty going to sleep or difficulty staying asleep. Chronic insomnia, on the other hand, is someone that suffered from difficulty going to sleep or staying asleep for 3 months.
Thanks for explaining that distinction. How do you perform a basic sleep evaluation?
The most important thing you can do as a nurse practitioner to evaluate sleep is just ask somebody, how do you feel like you're sleeping? Do you feel like you're sleeping good? Do you feel rested the next day? Because a lot of people, they'll lay in the bed all night long. They'll feel like they're not getting enough sleep. I've had patients that have came in and asked me for sleep aids, and I'll ask them, what time do you go to bed? And they'll say, I go to bed at 8, and I get up the next day at 9. And I'm like, how much sleep do you think you need? Because you're asking me to help you sleep 13 hours. And most adults only need 6 to 8 hours of sleep a night. We're not newborn infants that need 12 to 14 hours. So when you just quantify it with how long are you in the bed and how long are you actually sleeping, but there are people that don't need as much sleep as others. So if you feel rested the next day, then that's the most adequate evaluation of sleep quality, is how well you're performing and how well rested you feel the next day after a night of sleep.
How do you screen for sleep disorders like sleep apnea, hypersomnolence, and periodic limb movement disorder? When should NPs refer patients to a sleep specialist?
That's a really good question. And a lot of times when you talk to a patient and you're trying to find out, why don't you sleep good? What's going on? What do you feel like? Do you feel like you're having trouble going to sleep? Do you feel like you're having back pain that's contributing to your difficulty going to sleep? I always ask patients a little bit about, what's your sleep routine? What do you do when you're getting ready to go to sleep? We talk about sleep hygiene, and we'll get into that in a little bit, but what is the routine that you do? Do you take a hot shower right before you go to bed? Do you go run 2 miles? Because all of those can affect your ability to go to sleep. If you do something like take a hot shower because you've got back pain, then that can increase your body temperature, which can affect your melatonin levels, your cortisol levels, and those can all affect sleep. So as a nurse practitioner, when we're talking to a patient and they tell us they're taking a hot bath or getting in the hot tub or something like that right before they go to bed, you can advise your patient it might be better to take that hot bath about 6 p.m. if you're going to bed at 9 p.m. to kind of let everything stabilize again. If a patient's running right before they go to bed, you might talk to them about, if you're exerting yourself, that increases your heart rate, and that can make it difficult to wind down and get you ready for sleep. Same way, if a patient is crawling in bed and watching TV and eating in bed and everything, then that can confuse the brain that you're in bed to watch TV and eat and you're not in bed to sleep. Well, I just talk to them about their routine and see what they do. And a lot of times when you develop a good sleep routine, like I always set the coffee pot for the next day, I take my nighttime pills, I bring the cat in, I turn off the TV, I turn off the lights, I check to make sure the doors are locked, then that's kind of telling your brain, hey, she does this every night before she goes to sleep. I better start winding down because I have a feeling we're getting ready to go to sleep. So those are the kind of things that I always ask a patient about for their sleep routine. Sometimes things will pop up in an evaluation that you had no idea. I had one patient that said he couldn't sleep because his wife sewed in the bedroom all night long and made quilts all night. And I said, what do you mean she's making quilts all night? And he said, well, her sewing machine's in the bedroom. And that's when the kids go to sleep, and that's when she likes to sew. I asked the wife if she was there, and I said, can't you sew in the living room? Because the light's on and everything. He can't sleep with the noise. And she said, I never thought about moving the sewing machine. So sometimes those little things will come in. I had another patient that said she set an alarm for every 2 hours to go check on her sick dog to see if her dog had died. And I said, so you wake yourself up every 2 hours to see if your dog had died. What would you do if the dog had died? And she said, I guess I would wrap the body and put it in the garage. And I said, well, couldn't you wait until the morning? And then if your dog died, took care of it? And she goes, I guess I could. So a lot of times when patients are explaining that kind of thing, there are little quick fixes that you can do. And when you're talking about obstructive sleep apnea, periodic limb movement, and hypersomnolence, when you're talking to a patient and you're just wondering, is there something else going on besides my basic sleep evaluation here, you might want to think about some of those sleep disorders. If a patient's overweight, you can do an oral airway exam, and you can look and see, do they have a really tight airway? That's called a Mallampati score. And you can look and see maybe their tongue is high placed. That's a Friedman score. So that would put them more at risk of having sleep apnea. Do they have a large neck? You might want to measure the neck and see if they do have a large neck. And you might ask their sleep partner, do they snore? And ask the patient, do you startle awake? Do you like come to a startle? That could tell you that you're having sleep apnea and you quit breathing and you're startling awake. So those would be things to consider about for that disorder. Periodic limb movement is someone that kicks their legs and their limbs all night long. So you could ask the sleep partner, do they thrash in the bed? If the patient sleeps alone, ask them, are the sheets in disarray in the morning? Are the blankets on the ground? So those are indications of sleep movement disorders. There's one called rapid eye movement disorder where they're in REM sleep and they act out their dreams. They might punch, they might talk. So that's another sleep disorder you might think about. Hypersomnolence is something that you kind of think about with narcolepsy, and those are typically patients that are tired all the time. They have difficulty focusing during the day. They like to take naps. They go to bed as soon as they hit the pillow. If you have a patient that just looks sleepy, like they have bags under their eyes, they're not as focused, you might want to think about hypersomnolence, narcolepsy, and those are the patients that you would refer to a sleep specialist, like a pulmonologist, a neurologist, someone that does sleep evaluations, to do either a home sleep study where they take like a SAT probe and go home and see how many snoring events they have, how many apnea, hypopnea indexes they have, or they might bring the patient in if they're thinking periodic sleep movement disorder, and they might bring them in for a full sleep study where they monitor them throughout the night and see what their sleep looks like, how quickly they go in and out of the sleep stages. So that's a more in-depth study, but we can do just a basic home study where they just bring the apparatus home and then we download the results looking for sleep apnea.
We appreciate your insights for screening. What is sleep hygiene?
Sleep hygiene is what I was talking about a little bit ago. That's to make sure that you have the most conducive environment to sleep. So right before you get ready to go to bed, like I was talking about, develop a sleep routine. Put yourself into bed in comfortable clothes. You don't want to sleep in your regular clothes that might be tied around the waistband. You don't want to leave the TV on. A lot of people say, I have to sleep with noise in the background. There's a difference between white noise and there's a difference between watching TV to go to sleep. So a lot of times if you're watching a TV program and people think, this is really good, it helps me wind down, it really doesn't, because you have to engage your brain while you're watching TV. And it could be something silly, like you could see someone on the TV show wearing a red dress, and you could think, I don't think I have a red dress. I haven't seen that red dress in a while. I wonder if I took it to the cleaners. Did I pick up my cleaners? It starts waking up your brain, and it starts firing your brain in different areas. Or you might be watching a mystery, and you think, have I seen this show before? Who is the murderer? So you're starting to call up different areas of your brain. So it's firing your brain and it's not relaxing your brain. A lot of times when you watch TV, the volume changes. It could get really loud, then really quiet, and then really loud again. So those are startles, and that can affect your ability to go to sleep for the sleep latency. So it's not a good idea to watch TV in bed. And with sleep hygiene, we always say you should never be in bed for more than 30 minutes. The bed is for sleep and sex. It's not for watching TV. It's not for working on your computer. It's not for doing anything else like that. And when I've had patients that have difficulty going to sleep in their bed because they've had all these issues before, as you start walking back to your bedroom and you have difficulty going to sleep, a lot of times patients will go, I didn't sleep last night. I haven't slept for 2 weeks. I never sleep in this bed. And patients will always tell you, I sleep so good on vacation. I sleep so good when I stay in a hotel. That's because it's a new environment. And you haven't predisposed yourself to thinking, I'm not going to sleep good. I never sleep good. So with those patients, I just say, do you have a guest room? Tonight, why don't you go sleep in your guest room? And just that little change will help them sleep better. When we're talking about sleep hygiene, just remember, make it the most conducive environment you can have. I've had a lot of single people that like to eat in their bed and just watch TV in bed all night. And think about when you're trying to sleep and there's crumbs in the bed, there's wrappers in the bed's not comfortable, it's not cool. So sleep hygiene, just get a sleep routine and just make sure it's the best environment that you can have to help you sleep. And we'll talk a little bit about maladaptive coping behaviors of sleep. And those are things like stimulants, like people might drink alcohol to help them go to sleep. And actually, it might help you go to sleep, but it's going to be a fitful sleep because you'll wake up frequently throughout the night. It's not going to be a restful sleep. And if you don't sleep good the next day, but you've got to go to work, a lot of people will drink a whole bunch of coffee to wake them up. Or they'll smoke a bunch of cigarettes to get them going. Or they might take another type of stimulant. Maybe they're on Adderall, Concerta, something like that because they're having trouble focusing. And when you take any type of stimulant like that, that affects your sleep latency where you have difficulty going to sleep that night because you're constantly coming up and down off of that rush. So those kind of patients, they might also take some Tylenol PM to help them go to sleep. So they're constantly feeling those highs and lows, and that can affect their ability to go to sleep. The main thing with sleep hygiene is just to think of what helps me sleep, what makes it conducive. Don't work out, take a hot bath, have the TV going. They said there wasn't a lot of insomnia before the 1960s because TVs would turn off at night, and we didn't have the ability to stay up all night and have the TV on. And when I have patients that say they like that noise of the TV, I advise them to put a fan on or to do some kind of white noise machine, but a TV, a radio, because when people talk, it wakes you up because you think someone's talking to you. So it doesn't help you go to sleep. A fan is a much better option.
What should be the initial steps of treating insomnia?
The initial steps of treating insomnia is I always start with if there's something that's affecting the sleep, like the situation I told you about with the wife sewing all night long or the lady setting her alarm. I had another patient that would put an eye drop in right before he went to sleep, and then he'd wake up an hour later and put the other eye drop in. And I said, why are you doing that? And he said, well, I'm afraid when I go to get in the bed that I won't be able to see that eye drop will occlude my vision. So I wait an hour and then I put the other one in. And I said, well, why don't you just wait until you're in the bed and do both eye drops? So a lot of times it's not the patient trying to be difficult or anything like that. It's just they haven't thought. And they set up these little things that affect their sleep and they have no idea of knowing. And then when you just explain it to them, they're like, oh, my goodness, that makes such perfect sense. So I always start with just evaluating their sleep routine, their sleep hygiene, see what we can do. Advise them to eat in the living room, eat in the dining room. And another thing, if you're not asleep in 30 minutes, get out of the bed because all you're going to do is cause more aggravation and anxiety. So get out of the bed, go in the living room, watch TV. Then when you start feeling tired, go back and try again. But the patients that just toss and turn all night long, that just makes it more of a terrible experience for them. So get up, make a change, and go back when you feel like you're tired again. And also those patients that think they need to sleep 12 hours, push your bedtime back by 1 hour. So if you always go to bed at 10, but you lay in bed all night, I always tell them to go to bed at 11. Then you're really tired and you should be able to go to sleep. We try with some sleep restriction, wake up an hour earlier the next day, and also keep the same sleep routine on the weekend. It's not a good idea to sleep till 11 on Saturday, take a nap, and then do the same thing Sunday, and then try to get up early Monday. Try to stay on the same sleep routine with the same sleep times.
We appreciate those sleep routine tips. How can NPs convince their patients to try these steps instead of prescribing a sleep aid?
Sleep aids actually just add more to the sleep problems. They don't treat it. I always have my patients come back sooner. You don't tell them, oh, just go and develop a sleep routine and then come and see me next year and we'll talk about it. Because if the patients think they're coming back in, they're going to have some data to share with you. I tell them to keep a sleep diary. What time did you go to sleep? Did you take a nap the next day? Did you feel rested the next day? So when we can look at this information, did you nap? I restrict all napping because if you're having insomnia, there's no reason you need to be taking a nap because you're going to have difficulty going to sleep. So I like to bring them back in 2 weeks and say, let's look at the data. So when you implemented the changes and you implemented your sleep routine, do you feel like it helped you sleep? Do you feel more rested? Because a lot of times they forget how bad they felt. And if you give a patient Ambien or something like that, a lot of times they'll self-medicate and they'll take more than they're supposed to take. They'll take it too early. They'll take their husband's Ambien. They'll pass around the Ambien. I think it's important to bring them back in where you're more invested in them and you're looking at the information from their sleep diary.
Are sleep aids bad?
Sleep aids are bad because they add to dependency and they do not treat the sleep. They actually just build upon it and they put the patient to sleep too fast. And then when the patient gets used to going to sleep too early, if their bedtime should be 10, they might start going to bed at 10:30 because the sleep aid they can take and go to sleep faster. They also have a hangover effect the next day, and that can affect their ability to concentrate. If they take a over-the-counter prescription aid like Tylenol PM, a lot of patients take Benadryl. Those have a lot of anticholinergic effects like constipation, dry skin, confusion. So they're not a good thing to do. It's better to just work on the basic sleep hygiene and rule out any sleep disorder that needs treatment, of course, like the obstructive sleep apnea, the periodic limb movement, the rapid eye movement, behavioral disorder, those kind of things. It's better to treat the cause versus just to give them a sleep aid to make them go to sleep. So yes, sleep aids are bad.
That's good to know. Sounds like a Band-Aid resolution rather than treating the actual cause, right?
Exactly. But again, do not ignore them if you think they have sleep apnea. You don't want to totally ignore a sleep disorder that's undiagnosed. Sleep apnea can be very important to treat. It can add to cardiac dysrhythmias. So it's always important to make sure that they don't have an underlying sleep disorder that we're missing.
How much sleep is enough? And how can I tell if my sleep is good or not?
We kind of hinted on this earlier, but everybody needs good sleep, and everybody functions at such a better level when they've slept well and they're well rested. So even as a nurse practitioner, you need good sleep. So you should always make sure that you're following these tips that you're giving your patients and making sure that you're getting adequate sleep. And make sure you have time to sleep. Some patients will think, I only have 4 hours to sleep, but I need to be on point tomorrow. So I'm going to take an Ambien so I'll sleep really good. You won't sleep really good. You'll have that hangover effect. You'll go to sleep fast, but it won't be a restful sleep. To have a restful sleep, you need to go in and out of all the stages of sleep. And if you just compound it so much, you're going to skip some of your sleep phases. So it's not a restful sleep. But like I said earlier, there's some patients that require 6 hours of sleep a night. There's some that require 10. The most important indicator is how well rested you feel the next day and how well you function. So on average, it's 6 to 9 hours for an adult. Certainly children and infants need a lot more sleep. As we get older, we do not need as much sleep. Once we pass the age of 60, we don't need as much sleep. So those are good things to consider. And one of the take-home points should be ask your patients what's affecting their sleep. Think about things if you're prescribing a diuretic. Make sure the patient's taking it in the daytime, not at night, so they're not getting up all night to go urinate. If they're getting up all night long to urinate, but they're not on a diuretic, do they maybe have an underlying urinary tract infection? Is their pain medication not adequate? Do they not have a comfortable mattress? I can't tell you how many patients I've evaluated, and they tell me they've got a mattress they've had for 40 years and it's got a big divot in the middle. Always give them permission to go buy a mattress. Go buy yourself a good mattress. Find one that you can test out, because the first one's not going to be the most comfortable mattress. And you're in bed so much of your life, like 30 to 40% of your life you spend sleeping. You need to invest in a very good bed. If you've slept in a Comfort Inn and that was the most comfortable mattress of your life, ask the hotel what kind of mattress they have. Pull back the sheets and look. But invest in a good quality, comfortable mattress and good sheet set, and it'll make a world of difference. And it can help so many things. And it really can make not only your physical, but also your mental health, and your relationships will improve with good sleep. So that's the thing that I would leave with, is invest in yourself and make sure you have a good sleep environment.
Sounds like good advice. Thanks so much for taking the time to chat with us today, Rhonda. We really appreciate it.
Well, thank you for having me.
For more great content from the Nurse Practitioner, be sure to visit us online at tnpj.com for the latest NCPD articles, columns, and much more. Please leave us a 5-star review on iTunes, as it helps with the podcast's visibility and helps us to keep bringing you this great content. Also, don't forget to follow us on Facebook, Instagram, and LinkedIn at the Nurse Practitioner Journal, and on Twitter at TNPJ_journal. Thanks for listening. This podcast does not constitute medical advice and should not be taken as such, and does not replace professional judgment or advice. The ideas and viewpoints expressed on this podcast do not reflect the official position of the speakers, authors, affiliated organizations, the Nurse Practitioner Journal, or Wolters Kluwer. Please note that the hosts of the Nurse Practitioner Podcast are not clinicians. However, we created the Nurse Practitioner Podcast to bring you relevant clinical information by NPs for NPs. Thanks again for listening.